Welcome to the Irish Practice Nurses Association online educational series for general practice nurses. My name is Teresa Lowry-Lenin. I'm a member of the Carlow branch of the IPNA, and today we will be discussing the topic of epilepsy. Epilepsy is the collective term for a large group of anatomical and functional disorders of the brain, characterized by repeated seizures and brief episodes of involuntary movement that may involve either a part of or the entire body. In Ireland, approximately 40,000 people are diagnosed with epilepsy. Globally, over 50 million people are affected, and an estimated 2.4 million people are diagnosed with epilepsy each year. The risk of premature death in people with epilepsy is up to 3 times higher than the general population, with highest rates found in low and middle income countries and rural versus urban areas. Let's look at the symptoms of epilepsy. Seizures can vary from the briefest lapse of attention or muscle jerks to severe and prolonged convulsions accompanied by loss of consciousness and loss of control of bladder and bowel function. They can also vary in frequency from less than one per year to several per day. Up to 10% of people worldwide have one seizure during their lifetime. One seizure, however, does not signify epilepsy, and epilepsy is defined as having 2 or more unprovoked seizures. Characteristics of seizures vary depending on where in the brain the disturbance occurs and how far it actually spreads. Temporary symptoms occur such as loss of awareness or consciousness, disturbances of movement and sensation including vision, hearing and taste, mood or other cognitive functions. Certain triggers which make seizures more likely include missed medication, increased alcohol intake, sleep deprivation, stress, illnesses and fever. Idiopathic epilepsy is the most common type, and in over half of cases there is no known cause. Epilepsy with a known cause is called secondary or symptomatic epilepsy, and the causes of secondary epilepsy include brain damage from prenatal or perinatal injuries, congenital abnormalities or genetic conditions with associated brain malformations, severe head injury, stroke that restricts the amount of oxygen to the brain, infections of the brain such as meningitis, encephalitis, and neurocysticercosis, or genetic syndromes and brain tumours. Epilepsy is diagnosed based on physical examination, neurological examination, blood tests, ECG, EEG, imaging tests, and MEG. MEG is magnetoencephalography, which is a non-invasive tool used to study epilepsy. Combined with structural imaging, it is known as magnetic source imaging, which is known as MSI. MEG measures small electrical currents arising in neurons in the brain, and these currents produce small magnetic fields. Let's now consider some of the treatments for epilepsy and look at the possibility of drug-drug interactions. The main treatment for epilepsy are anti-epileptic drugs known as AEDs. Surgery can sometimes be required for severe cases. The potential for drug-drug interactions should be considered when prescribing concomitant medication to a patient on AEDs. The NMIC provides up-to-date information on all AED-related inquiries. Drug-drug interactions in patients with epilepsy can have substantial effects on clinical outcomes and may often be predicted by the pharmacokinetic and pharmacodynamic profiles of the different anti-epileptic drugs. Many patients with epilepsy have comorbid conditions which require non-AED concomitant medications. Drug interactions between AEDs and contraceptive hormones needs to be considered due to risks including contraceptive failure, potential teratogenicity of AEDs, and reduce seizure control. There are widespread concerns about the teratogenic risks posed by some AEDs, and care must also be taken with use in pregnancy. Increased risk of neural tube defects and other major congenital malformations are associated with exposure to AEDs, particularly sodium valproate and carbamazepine. Current guidelines recommend a daily dose of 5 milligrams of folic acid prior to conception until at least the end of the first trimester of pregnancy for all women taking AEDs. Usually after 2 to 5 years of successful treatment and being seizure-free, anti-epileptic drugs can usually be withdrawn in about 70% of children and 60% of adults without any subsequent relapse. The next 6 slides provides a comprehensive list of the different anti-epileptic drugs that are available, and it highlights their uses and their side effects. You may like to pause the presentation at intervals and study the different drugs and their uses and their side effects, or you may wish to refer back to them later for your own study purposes. So now we will consider the first aid management for different types of epileptic seizures. Let's first look at the generalized onset seizures with motor features such as tonic-clonic or clonic or atonic features. The main thing, as we all know, is to stay calm, and if we can remember it, try to time the seizure when it occurs. Protect the patient's head and cushion their head. If possible, turn the person on their side, but don't restrain the person unless they are in actual danger. Let the seizure run its course. We must never put anything in the patient's mouth, although saliva can be wiped away. Turn the person on their side after the seizure stops and stay with the person until they recover and respond fully. Again, it's very similar type of first aid management with the focal impaired and complex partial seizures. To stay calm and time the seizure. Don't restrain the person unless they're in danger. Let the seizure run its course. Guide the person away from danger. Try not to agitate the person. Speak gently and reassure the person, and stay with them until they recover and fully respond. These visual aids are very useful reminders of what to do when a person has an epileptic seizure. Just a reminder to cushion the patient's head. Try to look for ID to see if they have an alert or a bracelet letting you know that they have epilepsy. Loosen any tight clothing to time the seizure. Turn the patient on their side when it's possible to do so. Try not to restrain the patient. Put nothing in the person's mouth, and again to offer help as the seizure ends. Some seizures can be quite minor in nature, for example, just fleeting absences. Again, stay calm and time the seizure. If the patient starts to wander, guide them gently away from any danger. Stay with them until they are fully recovered and responsive, and reassure them and explain what happened when they recover. There are instances when an ambulance should be called, and these instances are if the person is not breathing or if there are concerns about the person's breathing. Also, if it is a first known seizure, or if the seizure lasts longer than normal, or the seizure lasts for longer than 5 minutes, where the normal duration is not known for major seizures, or where more seizures follow on from the previous seizure without recovery of the patient, or if the person is injured, or it's a woman who is pregnant, or a person who has another medical condition. And of course, if there is ever any doubt, we should still call an ambulance. Globally, epilepsy can cause significant social and economic implications in terms of healthcare needs, premature death, and workplace productivity. Nearly 80% of people with epilepsy live in low and middle income countries. It accounts for 0.6% of the global burden of disease. Diagnosis and treatment of most people with epilepsy takes place in primary care without the use of sophisticated equipment. In low and middle income countries, however, 75% of people with epilepsy may not receive the treatment they need, and this is known as the treatment gap. A recent study carried out in 2016 found the average availability of generic anti-epileptic medicines in the public sector of low and middle income countries to be less than 50%, and this may act as a barrier to accessing treatment. The World Health Organization Health Development Projects indicates that training primary healthcare professionals to diagnose and treat epilepsy effectively reduces the epilepsy treatment gap. Although social effects vary from country to country, people living with epilepsy can be targets of stigma and prejudice. Discrimination and social stigma surrounding epilepsy worldwide are often more difficult to overcome than the seizures themselves. The stigma of the disorder can discourage people from seeking treatment for symptoms so as to avoid becoming identified with the disorder. Epilepsy Ireland carries out tremendous work to raise awareness and offers a wide range of services and supports for people with epilepsy in Ireland and their families. Epilepsy Ireland aim to achieve a society where no person's life is limited by epilepsy. They have headquarters in Dublin and regional offices in Cork, Dundalk, Galway, Kerry, Kilkenny, Letterkenny, Limerick, Sligo and Tullamore. And their website also offers invaluable information and resources and is available at www.epilepsy.ie. So let's now consider the role of the practice nurse. Communication is very important, and this includes telephone triage, providing timely access to advice when necessary. Education and support about the patient's diagnosis, their self-management and living with the condition and its impact is important. We help to promote patient independence and encourage them to live well with their condition. We act as advocates. We provide counselling service. The scope of nursing practice has evolved greatly over the years, and many nurses are now able to prescribe drugs, perform diagnostic examinations, and prescribe other types of medical treatments either independently or in conjunction with a doctor. A multidisciplinary and holistic approach by allied health professionals is essential in meeting the complex needs of this population of patients. Nurses are ideally placed to contribute to the screening and detection of comorbidities associated with this condition, such as depression, anxiety, or suicidal ideation. Nurses offer early education and support, which can serve to reduce anxiety and depression in patients. A large part of our role is monitoring, evaluation, and audit of care. We provide education and awareness to communities about epilepsy, and many nurses are leading the way in quality improvement initiatives and research. So this is the list of references that were used in the production of this presentation. I hope you enjoyed this presentation on epilepsy, which is part of an online educational series for general practice nurses produced by the Irish Practice Nurses Association. I'm Teresa Lowry-Lanin and I'm a member of the Carlow branch of the IPNA. Thank you very much for listening and watching.